NOSM's COVID-19 weekly rounds. I'm Dr. James Kurtzen, a family physician here in Thunder Bay and the Associate Dean of Continuing Education Professional Development at NOSM. We're going to have a great rounds today, a very relevant topic, quite engaging. It's COVID-19 and the pandemic palliative care. To just bring your attention to the COVID-19 rounds webpage, where you'll find lots of relevant information. Just want to point out that we have our evaluation button on the rounds page, and if you would like to register to receive study credits, simply hit the button at the end of the session. It takes about 3 minutes, and by including your name and email address, it'll be our ability to forward you a study credit certificate for attending any of the rounds. Our future rounds, you can see, are already listed. Next week, Dr. Ken Milne is part of Northern Constellations, and the rounds will be for the first hour. And then you can see we have a number of presenters through the rest of May, which have been confirmed. On the website, the rounds website, you can see that you will be able to access the slide set, which is being used today, and it's already available, and certainly you can access it. And you can access any other of the presentations that have happened in the past. I'd like to just point out to you the NOSM COVID-19 online resource page. As you can see, we have the case status report for Northern Ontario, and as of this morning, 251 cases, although you can see the vast majority, 193, have resolved. We have presently 52 active cases in Northern Ontario. You'll note that we've had 6 deaths related to COVID-19, and that at present, we have a number of COVID-19 cases in several of our Indigenous First Nations communities in the north. As well, on the website here, you'll notice that we do have palliative care resources. And so there'll be a number of resources that are relevant to the presentation today. And as well, our presenters will also be giving you some other resources that you can access in the future. And finally, for all of you involved in teaching, there are some specific resources to assist you in your role of teaching and engaging learners while you provide virtual care and care to patients during COVID-19. Just a reminder that keep your computer on mute and turn your camera off. That will give you much better quality images, and that the planning committee for COVID-19 rounds has no conflict of interest of relevance. And throughout the presentation today, please forward your questions through the chat feature in WebEx, and the chat questions will be forwarded to our moderator, who will organize during our question period. First of all, I'd like to introduce Dr. Francis Calbertis to you. Francis is both a friend and a colleague. Francis is a family physician and is presently practicing on Manitoulin Island. As a family physician, Francis includes palliative care in her practice. She's also a NOSM preceptor, a medical educator, a scholar, and involved in research activities as well. I'm just going to turn it over to Francis so that she can introduce the rest of our presenters and our panel. Over to you, Francis.
Thank you, James. Can you hear me? Okay. Thanks, James, and welcome to you all for attending today's rounds. It's a real privilege to be part of this team. I thought today that it was appropriate that we present, being May 1st, on the subject of palliative care during an unprecedented global crisis. Today is May Day, which makes me think about the term Mayday, which is an international distress signal. It comes from the French m'aider, which means help me. So I don't know if you planned that, James, but thanks. Our group of presenters today are family physicians with palliative care certification who practice across Northern Ontario. As a group, I think it's safe to say we're passionate about palliative care education, its effective delivery, and its practice. Kevin Bezanson and Kevin Miller will provide today's formal presentation. The Kevins are based at the Thunder Bay Regional Hospital, and they consult widely across Northwestern Ontario in hospital, in hospice, in long-term care, and in the community. They share the position of regional co-lead for the Ontario Palliative Care Network, that's the OPCN, in the Northwest, hence their nickname, the Coco Kevins. Kevin B brings international and global perspectives of palliative care through his research examining and supporting palliative care and humanitarian crises. Christine Pan has dual certification in palliative care and emergency medicine with focused practices in both. Formerly of Elliott Lake, she is now based at Health Sciences North in Sudbury in the ER and the outpatient oncology departments. She's currently the acting regional co-lead for the OPCN in the Northeast. Christine has an interest in palliative care education in general and advanced care planning and goals of care conversations in particular. Before we start, I'm going to share with you a common perspective that our group holds. The current extraordinary time we're living through has resulted in a situation that we have rarely seen in our palliative care experience. And that is that both disease-focused acute interventional care and palliative care practice are practiced and discussed concurrently around COVID-19. I think it's a fair statement that our medical culture is usually holds these separate in a type of false dichotomy, where palliative care starts where all attempts at disease intervention ends, in an either-or situation. This global pandemic is teaching us otherwise, a both and reality. And with that, I'll hand it over to the Kevins.
We're gonna, I think, start with the Kevin Miller of the Coco Kevins. James, if you can bring up our slides for us there. I'd ask for a drum roll, please. Everyone can advance. We can talk about our conflicts. We have no sponsorship or financial interest specifically, although like many of the panel and others, we do work for a nonprofit organization called Palliative, delivering palliative care education, and they do pay us for that. I think it's also important, as Kevin and I chatted before, is that sometimes in palliative care, we will use medications and we will discuss them in what's referred to as off-label indications, but we'll try and point that out as we do so as well. Kevin, did you have any other comments there? It's a no shaking head for anyone who can't see him. And we can do the next slide, please, James. Our goals today, we're really, as described in the handout, is really describing the goals of care discussions in the face of COVID-19. And our second hope is that we can spend some time specifically looking at the tools and how to use symptom management tools in end-of-life care and how that might specifically relate to COVID-19. And although we do circle this into the content and the context of this global pandemic, as Francis pointed out, all of these things are essential at any time in care, and I think that this has been able to give us a highlight of the role that we can play when we're palliating all of our patients. It doesn't matter what the disease is, and hopefully this is something that everyone can take as they move forward. Next slide. One of the challenges, as George Bernard Shaw indicated in 1973, I think this has been widely attributed to him, is that the single biggest problem in communication is the illusion that it has taken place. And when we're doing anything with our patients, I think we often can be at fault for making assumptions that what we think our patients want, or what we think the patients need, or what we think the patients understand is something that has been communicated and clearly understood by them. And many times that's not the case. And so I think we need to start with an understanding of what is each of our patients want. And this is going to permit us to be in a better position to engage and really provide most effective patient and family-centered care. The next slide. So we're using a number of different terms, and of course today we're talking about the goals of care, which is the middle of our little brief diagram here. But I think goals of care discussions are part of a trajectory, and we often look at these as being the early interventions with advanced care planning. Advanced care planning may happen before the onset of significant morbidity or mortality associated with disease around times of diagnosis, but simply also being prepared in terms of understanding what might happen if you do get sick. These are discussions with patients and their families around an understanding of substitute decision makers and what in Ontario, the hierarchy might be for the Substitute Decision Makers Act, and we can refer to that or answer questions specifically. Today, we're going to focus on the goals of care, the middle bubble in our diagram. Goals of care discussions build on a foundation of advanced care planning discussions, but really are focusing again on goals. And in much the same way as we might talk about substitute decision makers, it's very important that the patient and the people who are important to their decision making are present for these discussions. These are understanding the values in the presence of active disease or of current morbidity, and what the goals might be. And I think in a very relevant and perhaps understanding context, in the event that I acquire COVID-19, what are my goals? And what are my expectations? What are my hopes? And these discussions with patients and their families and substitute decision makers will help us to guide the treatments that we offer. And this is very different, of course, from consent, which is the specific and relevant to the immediate course of treatment and asking for consent from either a patient or from their substitute decision maker. Hopefully that's highlighting a bit of the variation between these different terms that we're going to use. We'll come back to this. Next slide. COVID-19 certainly has put this into the forefront, discussions around goals of care, and particularly because of the understanding that we're gaining as this disease causes havoc in different jurisdictions in Italy, in China, in the US. We've recognized that patients with significant medical comorbidities, heart disease, lung disease, kidney disease, etc., seem to be at much greater risk for suffering more significant consequences or more significant illness. And therefore, it is essential that we're talking not only with our patients who are sick, who are in hospital, who are in front of us, but I think it is inherent upon us as a healthcare system to start to have some of these both goals of care and advanced care planning sessions with patients and their families. When we were preparing for this, the panel and the committee really was thinking that it doesn't matter whether you're seeing patients. These are conversations, and the skills that we're talking about today are things that you can even practice in having discussions with our own family members. And of course, advanced care planning with family members is a challenge in itself. I think the committee agreed that it might be helpful for us to trade parents because it might be easier to have these conversations with someone else's parents than our own, but it's at least a place that we can start. Next slide. So today, as we talk about some goals of care decision in the face of COVID, we're going to specifically be using the framework which is available, and I think it's you can get it on the link on the slides which are attached from the HPCO, which is the Hospice Palliative Care Ontario. This is a wonderful organization who has many resources, but specifically these goals of care discussion guides are available on their website and can give anybody some opportunity to have an understanding of what the framework might be for a discussion. And they have specific guides for patients in hospital, patients at home, patients who are sick, patients in long-term care. And I think that of course is one of the things that we've learned most significantly is the most significant impact that this disease is having, at least in Canada, has been on our frail elderly vulnerable populations in long-term care. So again, if it's important to have this discussion in general, it is essential that we're having these conversations in those settings. Next slide, please. So I'm not sure if people are referencing it, but I'll go through a brief. The goals of care communication can be approached in steps. Obviously, we need to be prepared, and that means that we need to have an understanding about our patients' conditions. We need to be aware of what their illness is, the impact it's having on them, And I think we need to have a reasonable understanding of prognosis. And that's not necessarily to, put a best before date on anybody of, September 22nd, but rather to understand that advanced illness may lead to an earlier death, that their prognosis could be measured in months, it could be measured in years, or many years, which I think would be a hope of many people. We need to have a skill in introducing the conversation, and I think there's not necessarily a wrong way to do it. Of course, there's exceptions to every rule, and there's exceptions to that rule, but I think that it's wrong not to introduce the conversation. And so that by introducing it, we're not going to cause harm for our patients and their families to have these discussions. I am going to turn off my phone. Then we need to understand the patient's understanding of the illness and what's affecting them. We need to share information to make sure that we're on the same page, because oftentimes what our patients understand and expect in terms of their illness or their disease or their prognosis might be different than what we as medical professionals and clinicians understand. Once we're on the same page, I think then we need to understand their values and goals, what is important to them, about the quality of the life, or about how their life is lived, and how they might envision a future state in which their life would be acceptable or possibly unacceptable. We need to, in the face of COVID, share information about the impacts of COVID-19 and how that might affect them specifically. And then finally, we need to make sure to summarize that information, to share it and make sure that the patient is understanding and in agreement, but also to make sure that this information, after these essential conversations are completed and you've done all the hard work, are documented effectively so that others can share and understand what the patient's goals are. Next slide. So Dr. Bezanson, the other Kevin, and I thought that the best way to do this would be in a demonstration phase. And so we're going to do that. And of course, the first step to that is the preparation phase. And that means that we all need to have a good understanding of the patient that we're going to see. And Kevin has agreed to become Bevan Bezanson, a 74-year-old male, adult, married with 2 children. His wife, who he's been married to for 49 years, is and acts as his substitute decision maker. He has a significant history of diabetes and heart disease with ischemic cardiomyopathy and significant reduction of his cardiac ejection fraction, which is estimated at 35%, which is quite significant disease. As well, his previous smoking has left him with significant COPD, with an FEV1 39% predicted, again, which is severe obstructive pulmonary disease. He does live at home, supported by his wife and his son who visits him. He ambulates using a walker, but he has had a number of falls over the last few months. He required the EMS to come and get him up, but each of those times he had refused to go to the hospital. Next slide. Mr. Bezanson's family called your office today, and he called my office. He's been feeling worse. He's having troubles even getting out of his lazy boy. He's had more shortness of breath, and in fact started coughing over the last few days. His son had been on a business trip in Southern Ontario and had just come back. And so, of course, we're also concerned that he may have had now exposure to COVID. The family's been encouraging him to go to the hospital, but he has been very resistant and refusing so far, and was hoping to have a conversation about what these things meant. Our hospital is not presently in surge. We've done a very good job of planking that curve, and there is capacity at this point for medical care, but what we're going to do is try and demonstrate how this conversation might go. If you're ready, Kevin, and off mute. Ring, ring. Hello. Yes, have I got you there, Mr. Bezanson?
Yeah.
Yeah. I've had a couple calls from your family, and I understand you're not doing so well. I'm wondering if you're okay, though, well enough to have a bit of a short chat, and we can maybe figure out a good plan for you.
I think so. As long as I don't have to move too much.
Well, that's great. Now, with this type of conversation is absolutely essential to have, and I'm hoping that maybe your family's there with you. Could we get them on the line? Would you be okay with that?
Yeah. Can someone help me with this phone? Yeah. Okay. I think they're on.
Can you all hear me okay?
Yeah, we can hear you.
Good. So obviously, Bevan, it's really important that we're prepared for what can happen when someone has medical conditions. And of course, all these issues you've been hearing about the COVID virus mean that it's even more important right now. I'm hoping you can help me to understand, though, as we're discussing this, what you know about your heart and lung function and these diseases you're facing.
Well, I know my heart attack left me with a bad heart, and I know my lungs are bad from smoking, but I've been feeling okay until lately. I know that my blood work and my heart tests have been not getting any worse.
That's true. But you remember we talked before about how heart disease and lung disease often follow a pattern where they flare and get a little better, but it never goes away.
Yeah, I think you told me that I could expect to have some times where my breathing was a bit worse, or I might have fluid in my legs, but I've been pretty good this year.
That's good. I think you have been okay, but from what I'm hearing from your family, these last few weeks have been giving you a heck of a lot more problems, and really the last few days have been pretty tough. It's getting harder for you to breathe comfortably, and of course that's why they've, I think, been encouraging you to go to the hospital.
I guess you're right. But I'm worried. I'm worried I might get sicker with COVID if I go to the hospital.
You know what, that is a common worry I'm hearing a lot about. I guess I really want to reassure you and your family, though, that at least at the present time, our healthcare system has been doing a very good job at caring for patients and really minimizing the risk of developing COVID. Can you tell me maybe specifically what you're worried about the COVID virus?
I hear that people like me with heart problems and lung problems get a lot sicker, and if I get sick, I might not be any ventilator for people like me.
Oh, you know what? Those are certainly valid concerns. But maybe if I could talk specifically about your conditions and what they mean in terms of your future or prognosis, and then we might be able to specifically talk about ventilators. Is it okay if I talk about really some life and death type of issues?
Yeah, I guess so.
Well, although you've had stable disease, you said your blood tests and the echo or the ultrasound of your heart have been okay. Remember, we talked about what stable numbers mean. These stable numbers, although they're stable, are still telling us you have very advanced heart failure and very significant chronic lung disease. And patients with such serious disease are often more fragile and have much more risk of a small thing or potentially a simple issue becoming fatal. And of course, that's specific and relevant to you, and especially COVID could be that one thing that tipped things over and could be fatal.
That sounds pretty bad, but I hear it's mostly people from nursing homes who are dying. I guess I'm lucky I don't live in a nursing home.
It's a good point. People in nursing homes often have many medical conditions, and that means that they're not able to care for themselves, but they're vulnerable and they have little reserve. I think, although you've been managing at home for the last little bit, and of course supported by your wife and son, you're also vulnerable based on these health problems. You said you're lucky you don't live there in long-term care, but can you tell me what you mean by that?
Well, I never want to be forced to leave my home. I'm not ready to die, but I would never want to be forced to leave my home. I want to stay at home.
So I'm hearing very clearly that being at home is extremely important to you, and I think sometimes that comes with what are the expectations of being independent and being in control. And so of course it's really important for you to know that with the degree of heart disease and lung disease that you have, it would be expected that people can become unwell enough to care for themselves. And so that even with good family supports, oftentimes people can't live at home because they become too weak. I mean, imagine how hard it would be for you and your wife if she had to feed you, bathe you, and toilet you, 24 hours a day, 7 days a week.
Well, yeah, even though I know my family would support me, I don't want to be a burden. I would hate to live like that. I don't want anyone else wiping my arse.
Sure. Well, and of course we do have treatments for the severe heart disease and lung disease, but those treatments get harder over time. And oftentimes as the treatments get harder, they also get less effective and you get less benefit. For patients with severe lung disease like you, there's also evidence that invasive ventilators can in fact cause you more harm than good. Sometimes there's other things, something called BiPAP that could be considered. But I think really the key here, Bevan, is if you got so sick that your body could only manage and needed those devices, that generally we would feel that you had such a serious risk of not being able even to get back to the way you are now. So that means that, although there are resources in Ontario now, it's quite possible that those things might not even help you.
Are you saying you can't treat my heart disease or lung problem if I get sicker?
No, I'm not saying that. What I'm saying is that those treatments might not make you better, or they might not even make you feel better. And some treatments, as I said, like the ventilator, really wouldn't necessarily be part of what we could offer you. We are lucky though in Ontario and in Canada because there's medicine and we have skills and knowledge with palliative care to help to make sure that you're comfortable, to make sure that even if you were that sick, that you wouldn't be suffering.
Well, it's really a lot to think about. I was kind of just hoping I could keep going the way it is, but I don't really want to get sicker. I certainly can't manage continuing the way I am now. I need to try something. The last few days have been really hard. If I go to hospital, could it just be for a short time so I could feel better and get back home?
I think it could be for a short time, and maybe what I'm hearing you say is that if you needed to go to the hospital, it would be acceptable.
Yeah, I think so.
Okay. So, well, I think at this point that's a good idea, and maybe I can summarize what I've heard from you so far. I think it sounds like at this point you are willing to go to the hospital and we can do some investigations and adjust the medicines and treatments, at least to start with. Once we get those that can hopefully help to improve your heart and your lung function, we would do whatever medical treatments could help you feel better and stabilize things. And that might include oxygen and other supports. And we would certainly do whatever we can to prevent you from getting so sick that you might not be able to breathe comfortably on your own.
Yeah, that makes sense to me. I really do need to do something to get feeling better right now.
Okay. So then no matter what happens, we're going to provide you with that support. We're going to try and help you be comfortable. And we don't have to make any final decisions, of course, now. And I think that maybe having some further discussions with you and your family about what the future might like is going to be important. But how about we meet over at the hospital as soon as you can get over there?
Okay, I still need to talk to my family some more, but I think that's right. I think that's what we should do now.
Perfect. Thank you.
Thank you.
So we can move ahead on the slide there. So I think what we've tried to do is to demonstrate, that this can be a very straightforward conversation. It doesn't necessarily need to take a lot of time. I think that, if there's questions about, kind of our comments or how we talk about it, we can pass that on through the slides. But I think that these are conversations that aren't difficult. They're pretty easy to discuss. And when people are sick, oftentimes they're thinking about a lot of these things. Of course, not all the conversations are as easy, but the only way to get good at these is to actually have these conversations and talk about it. And so I encourage everybody to practice. And when you do have more challenging conversations, that's of course where expertise is available from certainly the people as part of this panel, but lots of people in many communities to have those discussions with families. I'll pass on to, I think, to Kevin's portion of our advanced slide there.
Great. Thank you, Kevin. So So the sort of second part or second goal for today was to really kind of walk through some of the symptom management and palliative care guidance specific to COVID. And this is a tool that was, it's been borrowed and adapted from British Columbia, but has been tailored to the Ontario context. And I think it's probably, again, if I, I feel like part of our job when we're getting inundated with all of these various resources sometimes is to try and distill what's useful and going to be applicable for people who are obviously, as providers, you're caring for lots of other things at the same time that you're thinking about palliative care and COVID. So what I'm going to do is I'm going to walk through this sort of piece by piece a little bit and just talk about some of the specifics and some of the things just to make you aware of, and then hopefully we'll wrap up and have some time for questions. Next slide. So as we were just mentioning, we need to start from the very beginning.
Uh-oh, having difficulties on my... Here we go. Sorry, Kevin, it's not working.
Okay. Let's start from the very beginning. It's a very good place to start. When we read, we begin with ABC. When we treat, we begin with
ACP and GOC.
I'm sorry I had to subject you to that, but there it was. So again, just to remind that the things we just talked about are what comes first. So again, often in situations where there are a lot of concerns, the temptation is to kind of rush in and try and solve the problems. But if we don't know where we're headed, it's very hard to get there. So I think the other thing that has kind of been emerging from conversations that we've been having with colleagues around the country and around Ontario is to be aware that the condition and the symptoms that patients are experiencing, particularly with COVID, can really change very rapidly and sometimes require very dramatic dose escalations, more than what we're used to seeing, I guess, is what the messages I'm hearing from colleagues. Next slide. So just a reminder that opiates are really the backbone of managing dyspnea, and dyspnea is probably the most prominent symptom that we see in COVID-19. There are different reasons why we may or may not use particular drugs, but again, there's no reason not to start with the basics, and the basics are morphine and hydromorphone in the doses that are outlined there. A sort of separate protocol you see on the right-hand side, which sort of refers to people who are perhaps already on opiates. For example, patients who we've been managing for chronic medical conditions that require opiates. And I want to emphasize, further to Francis's point at the beginning, that this is concurrent care. So symptom management needs to happen even when the goals of care are very much geared toward treatment and potential recovery. And at the doses that we're suggesting here, we are not compromising people's respiratory status. So it's important to attend to people's symptom management needs, regardless of whether their goals are perhaps more palliative or more curative, in quotes. Next slide. When we're struggling with managing respiratory symptoms and the opiates are not adequate, we can consider adding in benzodiazepines specifically for the treatment of dyspnea, but also some of the anxiety and restlessness and agitation that go with it. If we're, again, on a more palliative trajectory and we're dealing with a lot of agitation and restlessness, usually methylprimeprazine is preferred if it's available. And I know there have been some issues with drug availability in various centers across Northern Ontario, but if it's available, it tends to be preferred, particularly for patients
on a more palliative trajectory because it is more sedating. And perhaps using something more like haloperidol in patients where the goals of care may be less palliative and more toward trying to minimize sedation. For severe dyspnea, one does need to give consideration once these other things if these other things are not adequate, to continuous palliative sedation. And there are protocols that have been developed. We're not going to go through all of that in detail today, but protocols that have been developed to guide how to do that. And essentially, way I explain it to patients is I'm providing them something similar to an anesthetic, something that's going to make them unaware of their symptoms and allow them to die a natural death, but to die comfortably. Next slide. Respiratory secretions can be a prominent symptom. I think it's the analogy again that I tend to use is one of snoring. So when the person is in the bed snoring next to you, they're not disturbed by their own snoring, but it can be quite disturbing to you. And that's really what end of life secretions. The reality is that it's because people are not conscious enough to be managing their own secretions that we get these symptoms. And again, just sort of highlighting that some are less sedating, some are more sedating. To be truthful, the evidence for all of these medications is somewhat limited. So a lot of our work is actually in educating caregivers as much as we can, and also in repositioning, which is often the most effective intervention. Next slide. There are some very specific issues we need to consider with respect to COVID-19 and the risk of aerosolization. So often we would use fans, for example, as a non-pharmacological approach to managing dyspnea, but we in COVID-19 would avoid doing that because of the risk of aerosolization. And you see the list there that we need to think about. And if we are needing to use those interventions, we need to adjust our PPE accordingly. Next slide. I'm just going to touch on this very briefly because it's an issue that I think that has come up here, certainly in Thunder Bay, and I think in other places too. And that is the issue of essential care partners, and recognizing that when patients are nearing end of life, this is a crucial consideration as to how do we facilitate connection with loved ones in a way that is safe and sustainable for our healthcare system. I think we've been fortunate in that our volumes have been low enough that I think we can even have this conversation. I think there are some situations where this is not possible, either because of the availability of PPE or because of the overwhelming burden of care that needs to be provided. But I've just outlined what is the current policy for us in Thunder Bay, and I don't know what the policies are across other centers in Northwestern and Northeastern Ontario. So that might be something we can discuss. We initially started out with a no visitor policy and recently changed the policy to a more permissive policy with escorted visits and PPE for COVID, highly COVID suspect or COVID positive patients. Next slide. So these are a couple of additional resources, and I think I'm gonna stop at that point, and we'll turn it over for questions.
And Kevin, maybe I'll just comment is that the change in the visitor restrictions here in Thunder Bay was really an ongoing process of discussions that were held with the powers that be as well, to really try and engage and find what was a compassionate approach. And so I think that if there is a very restrictive pattern in whatever jurisdiction you're in, I think it really is reasonable to have a discussion. We have to think about all these other factors and PPE and otherwise, and it can be done though in a compassionate way.
Dr. Curated, can you lead us off?
Yeah, I'll just make a reminder that if there are any questions, you use the chat. Please type them into the chat box, which is blue on my screen, little bubble, chat bubble. I do have a question though that I'd like to start with, and I think anyone can answer. but I'm sort of directing it at Christine. And right now, our situation in our clinical learning workplaces has changed. Undergraduate students are now no longer in any clinical unit, but postgrad learners are. So any thoughts on how to effectively include our learners both in and out of the clinical workplace in acquiring these skills and practicing them?
Sure, I'll start. Thanks, Francis. So what's been happening with before COVID with our collaboration with NOSM, it's been actually pretty amazing. Like when we started doing all the advanced care planning goals of care work with HPCO started the new framework, we've actually developed a simulation-based curriculum, initially for advanced care planning and now for goals of care as well. So we have been actually able to collaborate with NOSM so that luckily we, the week before we were closed down, we were actually able to have our second advanced care planning standardized patient simulation-based workshop with a second-year medical student during academic week. So they were actually able to get that, practice the framework and actually practice conversations with the with standardized patients. The feedback I've gotten from some of the faculty in the community is that now these students have become almost like a bit more of a champion in their practice. So, I mean, whenever they're let out again, that will actually be a good resource to use as well and teach each other and try and do that in real life. In conjunction with that, we also were able to collaborate with the family medicine residency to look at the goals of care part of it. And we had a simulation that was supposed to go up in April with the PGY2s. This obviously has been delayed, so we're going to have a modified workshop at the end of May doing that. What we've been trying to do is to encourage the learners and the preceptors to really kind of go out there and do it on everybody. Like Kevin was saying, like right now, if we can get them involved in any of the conversations over the phone through like a three-way OTM, which we do a lot in practice now in palliative care. I do it with my nurses. I can do it with like 3 or 4 people at once with learners. That will be a good way of engaging them and really having that almost like a real-time supervision as well and helping them out. So that's sort of one of the ways that we've been asking people to do it. If not, the other thing like Kevin was suggesting is let's trade family members and do it over the phone with each other as family members. Those are my initial thoughts. Anyone else?
Thanks, Christine. I think we are speaking here from a rural generalist basis, but I would just like to push a little bit the message that comes from Pallium Canada is that this is actually everybody's business. So Christine has been working with the PGY2s and family medicine, but our specialty programs at NOSM might benefit from this as well.
Oh yeah, I forgot. Sorry, Francis. Thank you for reminding me. So interestingly, last year when we first started the Goals of Care simulation, we actually ran a pilot. We had to call it a pilot because we were small scale. We could only run it in Sudbury, but we took the PGY 1s to 3s from the specialty programs that were supposed to go into the ICU rotation. So we call them the ICU residents. And we actually did a simulation with some of those too. So, and then last year we did an internal medicine, not so much a simulation, but at least a workshop on communication. So like you may see different specialty residents and hopefully down the road family medicine who actually have some of this skills being taught to them, and really the encouraging or the thing we're doing is to encourage everyone to then practice it in the real world. And definitely echoing Francis' comment, a lot of what I've been doing in Sudbury is I truly believe that palliative care, like I may be doing palliative care, but really I'm seeing a very small proportion of people who are actually dying, who will die. So really the skill set needs to be processed by everybody, family practice specialists, anybody and everybody, rather than really depending on us to be looking after these patients. So I'm more here to support everybody, but really hoping that everybody can do probably a better job than I do.
Thanks, Christine. And I would just expand that to say we are talking about physicians, but this is truly a task of an interprofessional team. So nursing, RPNs, all of our colleagues from social work, speech and language, OTPT, I think everyone can start this conversation or seek help and do it in tandem with a colleague. So I think we're going over to James for a question now.
So just wondering, in the midst of COVID, if I was looking after a patient at home who needs end-of-life care, what kind of home care resources are available right now? And you know, what's available in Thunder Bay, what's available in Sudbury, and what would be available in Manitoulin? Am I still going to be supported in providing end-of-life care at home? Over to you, Francis, in the panel.
Wow, that's a big question, James. And it was something I have been thinking about a lot. So my sort of question to the global community across the North is, you know, what are the minimum amount of human resources that we need in a community to provide this kind of service? We've already identified that the patients who are most vulnerable already have premorbid existing conditions and are likely undergoing a palliative approach to care anyhow if they have chronic lung, brain, or heart disease. This particular illness may escalate symptoms in a dramatic fashion. So in my current location, where we have, I would say, quite minimal access to nursing in the home, I have great concerns about this care being provided in the home when we have to sometimes think about escalating quickly from oral to subcutaneous route, from intermittent to pump dosing, when it takes us a long time to get equipment and people into homes. So I would say that here on Manitoulin, and I'm speaking right now from an individual perspective, is I do not think we have the resources to do that. And so we have to look to the hospital to say, what might our plan B become? Should we need to take care of more people at home, and to also recall that we've got social distancing. So the natural helpers, or the community of natural helpers and informal caregivers, is quite restricted. If you have greater access, for example, I used to work in a city, there was 24-hour access to nurses, there was shift nursing available. A rural practice is dramatically different in that context. So it concerns me also, the access to PPE, the time it takes to don and doff effectively, not to increase the risk to the healthcare providers, is quite huge. So this is a great concern to me, but I think we can have backup plans as needed if we recognize this. Any other comments?
Yeah, maybe I'll just speak to a couple of things that we've certainly seen. I think there has been an increased desire for people to have people stay at home and be at home because of the visitor restrictions, ironically, right? So people, particularly if they're not at end of life, but are poor enough that they need a lot of care, those are the folks, I think, that are struggling in many ways to try and figure out what this looks like. I think we've been somewhat fortunate in Thunder Bay, partly by virtue of lower numbers and also by virtue of having more resources, that we have been able to provide fairly robust nursing and even personal support in the home. I do feel like it wouldn't take a lot for that to unwind, particularly if we had a situation where somebody was positive and potentially then a number of nurses from any particular agency off of work, et cetera. So the PPE is a concern. It's a concern for providers, partly because, again, these are contracted. The providers are contracted, and so they are provided PPE, but the whole level of support around implementation and things has been hard to get a handle on, is maybe the way I would describe it. And then as physicians, we've also had to think about, much like anybody in a family practice, how do I access the appropriate PPE to the situation? And then there are just some practical realities. If you are going into a situation where you're concerned about COVID-19, it's actually quite tricky to don and doff PPE and dispose of it appropriately doing a home visit. There's actually a good resource that's been put out for kind of guiding people through that. But so there are a number of layers that make it more difficult to manage people at home. But I think interestingly, the paradox is that people would maybe, if possible, would want to be at home so that they can have more of their family present, potentially, as you said, their natural caregivers.
This is Kevin Miller, and I'll just maybe add to that, echoing what my colleagues have said. I think that at this time it really is very important for us to hear and listen to what our patients and their families are wanting, and typically as a palliative care team, that's what we're doing. But it takes that whole team to be able to make this happen, and especially now. So rather than saying it can or can't happen, I think it's a matter of sitting down and saying, okay, how do we try to accomplish those goals and what's important to our patients? The goals of care include being at home and receiving that care. Well, are there compromises that we would need to make in terms of the services or supports because of COVID or because of PPE? And does that render a decision invalid? And therefore we need to look at different options. I'm working with a client presently, and the thought was maybe going home, but that wouldn't work. Maybe going to family's home, and that won't work. And now we're thinking that maybe going to a hotel, kind of locally, temporarily might work. And so really, my wife likes to say, this is my first pandemic, so we're learning as we go. And I think that really is what this is about, is figuring out how we can make this work.
It's Christina. So just to add to that, in Sudbury, we are lucky in terms of resources, for now anyways, that there is a promise that we might be able to do this in a very selected population of patients for palliation at home with COVID. Some of the more practical side that we're looking at is, one, it's the symptom management, like how are we going to be able to do real-time symptom management if symptoms are going to change very quickly. So it may end up being, again, more a very select population. The second thing that we are looking at is really, what is the support system going to be like? I mean, yes, we do have home and community care, but at the end of the day, a lot of the care will be provided by the family members. So we're looking at making sure we have caregiver education, we have the caregiver guide, we have PPE available to the caregiver, and that's the last piece that we've been working on as a community team, trying to put this together, recognizing that at the end of the day, like Kevin Miller is saying, like, it may be a lot of compromises. It may be not the home that the patient is looking at. It may all default back to a hospital as a plan C, D, or E. But there's a lot of conversations going on to try and see if we can work out a plan that is going to work the best and is most consistent with the patient's goals.
Okay. We have a question from one of our interprofessional colleagues in Sault Ste. Marie, a PharmD clinical learner on rotation. Thanks for dialing in. Who is pointing out that many of the administered medications for end-of-life care needs are given on a PRN basis as symptoms fluctuate. Have any institutions across the north that we know of developed protocols to reduce PPE when accessing medications in hospital on a PRN basis? And I'm assuming that is the amount of times nurses have to go in and out of rooms, don and doff. Would anyone like to address that?
We haven't really done a lot. Well, first of all, we haven't really had a case or a lot of cases that require that. So I think at this point it's not an issue. There has been a lot of talks about, how do we pick medication that may have maybe potentially a longer half-life, like NOSM as opposed to Firsat, for example, that will kind of help us with the management of patients in these situations. So definitely that's a good consideration to have as we kind of get more patients that need the palliation, especially in hospital or in a setting where PPE becomes an issue.
Kevin Miller in Thunder Bay, and I don't know that it specifically addresses the the policy to address the number of times in and out, but we have tried to create a COVID specific unit where the staff are having access to that, and so that we having the cohort population, it's a little bit easier to make sure that we can allocate the appropriate resources where they are needed. But that said, over the last number of weeks, the caution about all of those patients who are waiting for their COVID, even though it might be a low risk test, all of us are ending up using more. And again, I think we need to be conscious of it. But I think that at the end of the day, depending on the availability in your environment, you need to have that exact conversation about what is going to amount to a compromise. And I would suggest, though, that a compromise on comfort at that point is maybe not acceptable, at least given our current resources, but that might change.
Thank you. I'm going to try to squeeze in one last question as the moderator's prerogative here. Number 7, I think, in the goals of care conversation is document and communicate. One of the challenges we see here, and I've seen in other jurisdictions I've worked in, is separate EMRs mean that previous documentation of conversations don't go from one part of the healthcare system to another, from your office to the hospital EMR, from your long-term care facility to the hospital. And as a clinician, even knowing that this conversation has happened once with a certain patient and family makes my role different from thinking that I am the first person ever to have this conversation, particularly in an emergent or catastrophic situation. So any comments? I know that we do all work in a similar hospital EMR situation. Any comments about seamless transfer of information across institutional boundaries?
Maybe I'll take a stab at this one very quickly. I'm not aware of any places that have got it completely right yet. But recognizing, this is an extreme challenge and of course makes everybody's job easier and improves patient care. One of the things we're working on presently is implementing a centralized referral and repository of information around our patients whom we are delivering a palliative approach to care. And what we're hoping is that, in fact, that this type of information would live there, and such that, so when the patient's at home and maybe I've gone and had this conversation, it's documented, and then that information is actually transferred and follows the patient. So the patient goes to emerge, a copy is then forwarded to emerge. The person goes to see their specialist, information is then follows that patient along and is updated and modified as they go. But we're getting to that. We don't have it yet. I'd be happy to hear if anyone else's suggestions.
I think this is Kevin Bezanson. I think one of the things that certainly, again, I would agree that I have not seen it seamlessly applied, and it's a challenge. Of course, the bigger the place, the harder it is. I think a couple of things. One is that colleagues in Marathon, I know, have been doing some work around, using one of these frameworks to actually have some place where it is documented in their EMR, in their family health team EMR, so that that information can be readily shared, faxed, sent, shared in a meaningful way if need be. I think the other it's very old school, but the concept of a warm handoff, not of that if you've had that conversation, part of your job as a provider is to reach out to the people caring for them directly to inform as soon as you are aware. And I think in some ways that conversation about the conversation may be the most effective tool.
Yep, I agree with all of the above. One other advertisement piece is that I'm really sold on the templates that HPCO has done on advanced care planning, and most recently on the COVID page, they've actually put out a COVID-19 or a goals of care documentation template. So what I've been doing, knowing some of the people in primary care, is really trying to advocate them to have the EMR vendor put those as a template so that it can be standardized across the province. So it's much easier to communicate if we at least have a standardized format to document.
Back to you, James.
Thanks so much, Francis. Just a reminder to our attendees today, please fill out an evaluation so we can give some feedback to our wonderful presenters. By filling out an evaluation, you'll leave your name and email address, and we'll keep track of your study credits. This rounds today was again study credited, and we'll keep track of those for you over the next number of weeks to months. What a presentation today. We had a role play, we had a little song, we had a panel from across the reality of the North with Francis from Manitoulin and Christine from Sudbury and the Kevin duo from Thunder Bay. I think it really reflects the reality of Northern Ontario, the nuances of providing care in Northern Ontario. Join us next week when we will have Dr. Ken Milne. Ken is an emerged doc from Essex, practices in a rural emergency department. And Ken is going to be both entertaining and innovative and educational. And he'll be giving a presentation from 12:30 to 1:30. And then at 1:30, we'll be having a bit of a celebration for our NOSM faculty, recognize some of the award winners this year in promotions. And please take care of yourself, stay safe. We'll see you next week. And as mentioned, please fill out an evaluation so we can give you study credits for attending today. Thanks so much. See you next week.